Greetings to all. You are attending the panel discussion titled COVID-19 in the Americas, What We Know and What We Don't Know. My name is Janelle Taveras, and I'm the Senior Advisor for Health Equity for the International Association of Providers of AIDS Care, and will be your moderator for this session in addition to two panelists that I will soon introduce. As the pandemic hits a one-year mark with over 91 million cases worldwide and 22.7 million of those in the US, we've learned some about how COVID-19 impacts people living with HIV. While the end of the pandemic may be in sight as vaccines are rolled out, the expected delay in vaccinating particular populations of lower income countries, which are often hardest hit by HIV, means that these lessons are still critical for us to explore and share. Additionally, there remain important gaps in our knowledge of addressing COVID-19 among people living with HIV. And finally, as the process of vaccination has only begun, much is left to determine about vaccinating people living with HIV, including to leverage existing networks and relationships in communities with poor medical access and high levels of distrust. Our two panelists are Dr. Chris Duncombe, Chief Medical Officer for the International Association of Providers of AIDS Care, and second is Dr. Amanda Castell, Professor of Epidemiology and the Milken Institute School of Public Health at George Washington University. Dr. Chris Duncombe is the Chief Medical Officer at the International Association of Providers of AIDS Care, IPAC. He specializes in the delivery of HIV public health programs with a focus on sub-Saharan Africa. Dr. Duncombe leads the joint UNAIDS IPAC Fast Track City Initiative, supported by PEPFAR and USAID. This initiative is providing technical assistance to 15 high-burden cities in Asia, the Caribbean, Eastern Europe, and Africa. Prior to joining IPAC, Dr. Duncombe was with the Bill and Melinda Gates Foundation in Seattle with the HIV department at the World Health Organization in Geneva. Dr. Chris Duncombe, you may begin.
Everybody to this session on titled COVID-19 and HIV, What We Know and What We Don't Know. So as the pandemic nears the one-year mark, we've learned a great deal about how COVID-19 impacts people living with HIV. There have been multiple case studies of COVID-19 and HIV published in diverse geographies. There are some examples on the right side of the slide. Right now, we have almost 50 studies that have been published. But while we have a robust understanding of the natural history of COVID and HIV co-infection, as Janelle mentioned, there are important gaps in our knowledge of addressing how COVID-19 affects people living with HIV. To this end, WHO last year said that there is evolving and conflicting evidence as to whether people living with HIV have an increased risk of acquisition of the virus or whether they have an increased risk of clinical complications, including death, compared to the general population. Further, WHO has said that a larger data set with a broader geographical representation is needed if we are to expand our understanding of the impact of SARS-CoV-2 co-infection in people living with HIV. WHO has established a global COVID-19 clinical platform with data from 79,000 hospitalized patients. 5,291 of those are people living with HIV from 30 countries around the world. So let's look at some of these evolving data. This was the first systematic review published in September of last year with 25 studies and 252 people living with HIV who developed COVID-19. And these studies came from China, from Europe. There was a small study from Uganda and Africa, and also studies from North America. The high-level conclusion that the authors came to is in the box on the left side here. Current clinical data suggests that the main disease severity and mortality risk factors are linked to older age and multi-morbidity, not particularly to HIV. But here we have data which is telling us a different story. These are data from two large public health databases, which report a 2 to 3-fold increase in death amongst people living with HIV who get COVID. The first database comes from the Western Cape Ministry of Health in South Africa, They looked at 13,000 COVID-19 cases with 435 deaths. And people living with HIV had twice the risk of dying from COVID compared to the general population. And this was irrespective of viral suppression or ART use. However, they did say that the risk was modest and that there may be other associated confounding factors that make these data hard to interpret. NHS England has a database called Open Safely, which was set up to monitor opening of England, which is now, of course, not reopening because of the second wave. But this Open Safely database covers 40% of the full English population, 17.3 million adults, including 27,000 or 0.16% with HIV. Data from this database tells us that there is nearly a threefold increase in the risk of dying from COVID-19 in people with HIV compared to those who don't have HIV, even adjusted for age and sex. So these are quite concerning data. If you look at data from the Veterans Affairs Cohort study in the US, they matched people with HIV and COVID, people with HIV and no COVID, people with no HIV and COVID, and finally people with neither disease. They found that among veterans, these are veterans who've been in the military, amongst veterans with COVID-19, there was no difference between the HIV negative group and the HIV positive group in terms of hospital admission, and the adjusted hazard ratio is here, intensive care admission, intubation, or death. So this is kind of quite different to what the other databases are telling us. In terms of increased risk of infection, this systematic review of 144,000 hospitalized patients from 14 studies in North America, Europe, and Asia, the pooled prevalence of HIV in patients with COVID-19 was 1.22%, and this is a twofold increase in the incidence compared to the general population of 0.65%, again telling us that people with HIV are more susceptible to getting COVID-19. However, there were differences, quite stark differences between countries. In the US, the risk rate was 1.43, but if you look at Spain, it was only 0.26. So there is obviously, there seems to be a geographical involvement in the risk of getting COVID amongst people with HIV. Here we see the opposite. This is no increased risk of infection. These are data from New York City, 204,000 cases of COVID-19, 2,400 with HIV, overall prevalence of 1.06%, and the prevalence of HIV in New York City is 1.5%. So people living with HIV were not overrepresented amongst people presenting with COVID-19. But if you look in the table here, comparing HIV positive and HIV negative status, there was an increased risk for people who are HIV positive of hospitalization, of intensive care admission, and also of death. So again, some quite worrying data. These data come from not New York City, but New York State, the New York State HIV Surveillance Registry, 108,000 people living with HIV in New York City. New York State, 2,000 diagnosed with COVID. They reported no difference in the percentage of people acquiring COVID compared to HIV positive and negative people, but again, they reported an increased risk of hospital admission and an increased risk of death, the same as I just showed you for the New York City data. Another systematic review, 205,000 people, 20 published studies. They reported excess mortality in people with tuberculosis, which is interesting, and also in people with influenza. But they reported no increased risk mortality for people with HIV or for people with chronic hepatitis. So again, you can see how the data are telling us quite different stories. This was just published a couple of weeks ago by our colleagues at Amphar, and they did a they analysed the relative risk of COVID diagnosis, of hospitalisation and death in 31 published studies, 6,947, people living with HIV with COVID. So these are really, really big numbers. And you can see the geographical spread here across different parts of the world, looking at diagnosis, hospitalisation and death. The conclusion of the authors here was, taken together, these studies indicate that HIV infection may be associated with increased risk of COVID-19 diagnosis, but comorbidities appear to play a larger role than HIV-specific variables in outcomes. And that's a similar conclusion to the very first systematic review that was published back in September. This is the first study I've seen that's specifically looking at immunodeficiency. This is 175 people living with HIV, 65 people from Milan, 61 from Germany, 49 from Madrid. Current immune deficiency with a CD4 count of less than 350 was independently associated with an almost threefold increase risk for severe disease. Mortality across these three studies was 4%, and the only factor that it was associated with increased mortality was a low CD4 count. So this is telling us that immune deficiency may play a role in increased severity and death. Finally, this was published just before Christmas by Anton Pozniak, the immediate past president of the International AIDS Society, just telling us that the data are indeed quite different depending on the setting, the way the data are analysed, and the way that the data are analysed. And that right now what we need to do is interpret these data cautiously. I think that there are signs there that there may be an issue that we need to pay attention to in terms of disease severity and also mortality. And we need to be careful that people living with HIV take all the precautions they need to take, that they don't get COVID. But right now, I think we just need to wait for more data to understand if this is really an issue or whether we just don't have enough data yet to draw a conclusion. I'll stop there and hand it back to Janelle. Janelle, you're on mute.
Thank you. Thank you,
Yeah.
Dr. Our second panelist, Dr. Amanda Castell, is a tenured professor in the Department of Epidemiology at George Washington University Milken Institute School of Public Health. She has expertise in using public health surveillance data to monitor progress along the HIV care continuum, runs a large longitudinal cohort study of over 11,000 people living with HIV in the DC area, and conducts technology-based interventions aimed at improving HIV testing, engagement in care, and treatment adherence. In addition to her research, she teaches courses in infectious diseases and is a volunteer attending physician at the Children's National Medical Center and Special Immunology Clinic at the DC Department of Health and Wellness Clinic. Dr. Castel is a board-certified pediatrician and prevention medicine physician and completed CDC's Epidemic Intelligence Service and Preventive Medicine residency programs. She leads the DC Center for AIDS Research, Ending the Epidemic Scientific Working Group, a member of the National Institute of Health, National Institute of Drug Abuse Clinical Trials Network, DSMB, and serves on the IPAC Board of Trustees. Dr. Castell's training and expertise in infectious disease outbreak investigations, applied public health epidemiology and surveillance have been used during the COVID-19 pandemic in her role as a case investigator, epidemiologist, and advisor to local health departments, universities, schools, and private businesses. Dr. Amanda Castell, you may begin.
Thank you, Janelle. And Chris, if you could show the slides, please. Just bear with us for getting the slides up. Wonderful, thank you. So I'm going to spend the next few minutes taking you all through what we know, what we don't know about the coronavirus vaccine and how it relates to persons living with HIV. Next slide, please. So just to kind of start us off as background, we know that there are a wide range of vaccinations that are recommended for people living with HIV. Here you can see the list, and just to point out that there are various types of vaccines available for individuals living with HIV, both those that are live vaccines or perhaps inactivated vaccines, and also that the recommendation varies based on a person's immune status. So sometimes some vaccinations are recommended for people based on their CD4 count and their immune status. Next slide. So in response to the COVID-19 pandemic, vaccine development really has been fast-tracked through different mechanisms such as Operation Warp Speed here in the United States. And we really have over 160 vaccines in the pipeline, but I want to highlight three main types of vaccines, two of which have already been, or three of which have already been approved by the U.S. Food and Drug Administration under the emergency use authorization. So the first type is the messenger RNA vaccines, and those are the vaccines that Pfizer and Moderna have been studying. These are vaccines that use that messenger RNA to try to teach our cells how to make a protein. And most of the vaccines related to COVID-19 are focusing on that spike protein, which then triggers an immune response and allows our bodies to produce antibodies that will then protect us from getting infected. Those studies have been shown to be from 95% to 94% effective, respectively. The Pfizer vaccine has 95% effectiveness after day 7, the Moderna 94% effective. The second type of vaccine are these protein subunit vaccines. So these include using harmless proteins, again, from that spike protein on the coronavirus, to then stimulate the body to make T lymphocytes and antibodies. And this way, if our bodies are ever introduced to the virus again, if we're ever infected in the future, then those memory cells will recognize the virus and fight it off. These vaccines are still in phase 3 trials, and so the effectiveness overall is still to be determined. And then the last type of vaccine that's really moved forward in the pipeline are these vector vaccines, which include the AstraZeneca vaccine that was developed in collaboration with the University of Oxford. So this approach is slightly different. It takes a weakened version of the live virus and uses the genetic material from the coronavirus and inserts itself into it. It uses adenovirus as a vector to do that. And then this prompts our bodies to activate memory cells like T cells and B lymphocytes, so that, again, once presented with the virus, we know how to fight the virus off if we're infected in the future. The AstraZeneca and University of Oxford vaccine has been found to be about 70% effective. And I just want to highlight that there's been a lot of discussion around these mRNA vaccines. While this is a relatively new approach to vaccine development, it has been something that's been used with cancer as well as with the development of other vaccines such as influenza, Zika, rabies, and CMV vaccines. Next slide. So the question is, how are people living with HIV, how have they been involved and enrolled in these coronavirus vaccine studies? And unfortunately, many of the studies initially limited participants to those that were healthier individuals who did not have any other medical conditions. And so while these early studies were able to show that the vaccines were safe and effective in the wider population, it's only now that we're starting to see people living with HIV who've begun to enroll in these vaccine trials and take part in these studies. And this, of course, is including those 3 vaccines that have received emergency use authorization. So to date, there have been relatively small numbers of people living with HIV in these studies with very short follow-up times. And so we unfortunately don't have any hard data yet that's available to make decisions regarding how people living with HIV will do with these different vaccines. Next slide. So just to show you where we stand in terms of these 3 vaccine trials. So the Pfizer study has enrolled 196,000 people living with HIV. While they have published their initial results in the New England Journal of Medicine, they did not include those persons living with HIV in those results. And per their protocol, safety results are going to be analyzed separately for that population. And just to give you a sense of the Pfizer overall numbers in their initial study, they had over 43,000 people enrolled in the study. With the Moderna trial, they now have about 179 individuals with stable HIV who were enrolled in the virus. These people were included in the phase 3 trial. And again, the safety data on this group of individuals has yet to be reported. And then finally, with the Oxford AstraZeneca vaccine trials, they've recruited 160,000 people living with HIV in the UK and South Africa. They also enrolled individuals living with HIV, but who were immunologically more stable. So CD4 count had to be over 350. They had to have an undetectable viral load and be taking antiretroviral therapy. And again, these data are not yet published in the main paper showing the vaccine efficacy trial results. Next slide. So given the paucity of data and the data that are forthcoming around COVID-19 vaccines and people with underlying medical conditions, there's been a lot of discussion around what to recommend. And so right now, the U.S. Centers for Disease Control and Prevention is recommending and reminding us that people living with HIV or who are otherwise immunocompromised or taking immunosuppressive medications may be at increased risk for severe COVID-19, as Dr. Duncombe showed us in the prior slides. And so data still are not available to establish the vaccine efficacy and safety in these groups. However, the recommendation currently is that immunocompromised individuals may receive the COVID-19 vaccinations if they have no contraindications to vaccination. But we need to make sure that we counsel them about this unknown safety profile. We need to make sure that we highlight there's the potential for reduced immune response in these individuals, and that in general, as just like with the general population, we really need to encourage people to continue to follow guidance to protect themselves from COVID-19, including wearing masks and social distancing. Next slide. So I did also want to highlight that another subpopulation that was not fully included in these vaccine trials is that of children. So you can see from the table that the Pfizer vaccine actually is authorized for individuals ages 16 and older. It may also be given to people who are at higher risk or considered essential workers, even if they are 16 or older. And then the Moderna trial is authorized, the Moderna vaccine is authorized only for individuals who are 18 or older. And they currently are doing sub-studies to enroll individuals who are 12 to 17 years of age. The AstraZeneca Oxford vaccine trial initially did include younger children, including those 5 years of age and older with parental consent. However, they were subsequently removed from the trial, and so we'll have to wait to see what happens with that vaccine in terms of getting data on children who are under the age of 18. Nevertheless, given that Pfizer and Moderna are looking at younger individuals, we anticipate that there will be some approval to vaccinate children in late 2021. Next slide. So in preparation for vaccine rollout, there's been many conversations and many organizations and bodies that have really started to determine how to ensure the equitable distribution of these COVID-19 vaccines, given the disproportionate impact on certain populations. And so here I've just highlighted two of those frameworks, one from the National Academies of Science and the other from the World Health Organization. And you can see that there's some similarities in terms of kind of those core principles in terms of fairness, transparency, equity, and really using the evidence base to inform who should get vaccinated and when. Next slide. So in terms of equitable vaccine allocation, again, here's the recommendation from the National Academy of Medicine in terms of the different phases of vaccine rollout. And then next to that is the ACIP recommendation from the CDC for their allocation of COVID-19 vaccines in people over the age of 16. And there is generally overlap in terms of the phase 1 individuals. Those should be persons who are healthcare personnel, who are older individuals or frontline workers, and who have comorbidities that may increase their risk of COVID-19 infection. Next slide. So despite these frameworks, I think, we always say that vaccines are not useful if people don't get vaccinated, right? So it's been really important for us to look at potential vaccine uptake and vaccine hesitancy. And these are data from the Pew Charitable Trust that were recently updated because there was some concern several months ago that there was low vaccine uptake and a lot of vaccine hesitancy among certain populations. And so while it looks like overall about 60% of US adults say that they would definitely or probably get a COVID-19 vaccine, you can see that it does vary based on different subgroups. And one group in particular that I would highlight here is that Black and African American individuals are less than 50% likely to get a COVID-19 vaccine, even though we know that they've been disproportionately impacted. So you can see in the graph that only about 42% of Blacks who responded to the survey said that they would definitely or probably get a COVID-19 vaccine. Next slide. So where do we stand in terms of distribution? Again, this has been somewhat controversial, but you can see that we really have the vaccine supply on hand. So there are over 22 million doses that have been distributed, but yet there is a lag between the doses distributed and the actual vaccination, with slightly under 7 million people being vaccinated in the US. And the map on the right shows you again, kind of the disproportionate distribution of vaccine based on states, because states were allowed to determine how they wanted to distribute their vaccines and to prioritize their own subpopulations. Next slide. So, we've learned a lot. We've been able to fast track the vaccine development process. We're still learning how the vaccines will be rolled out to individuals who have underlying medical conditions, particularly those living with HIV. And there's still several unknowns, however, with COVID-19 vaccination. So one is around dosing. So the vaccine efficacy after one dose may be able to enable mass vaccination. However, the clinical trials were not conducted in order to measure that vaccine efficacy after one dose. So that's still an unknown. There's been some discussion about the possibility of giving a half dose to people to allow more people to receive the vaccine. This happened somewhat with the AstraZeneca-Oxford trial, but there's still some questions around whether or not that's feasible. And then if there were to be a shortage of the vaccine distribution for one type of vaccine, if people receive that first dose, there's still an issue about whether or not they should get a second dose using another vaccine. Recently, in the last couple of weeks, as we've all seen, there's been the emergence of these variants with COVID-19. There are two lineages, one that has originated in the UK and is now in the United States and Canada, and another that's originated in South Africa. And so there are questions around whether or not these vaccines will remain effective given those variants. Pfizer has looked at a small number of individuals, I believe about 20, who have received the vaccine to see whether or not the vaccine still neutralizes those key mutations. And they found that it does for the UK lineage. However, they have not tested it for the variant that's emerging from South Africa. And then another issue and another unknown is the effectiveness of the vaccines in preventing asymptomatic infection and as well as preventing transmission. We know it prevents the clinical manifestation of COVID-19, but we don't know whether or not it will prevent asymptomatic infection and further transmission. Similar to the flu vaccine, there are also discussions around whether or not the vaccine will be durable for longer than 1 year. So the durability of vaccine protection is still an unknown. It could be that we end up having to revaccinate individuals annually or maybe more periodically than anticipated. But again, the studies were done and so quickly, and the period of follow-up is so short that we really don't have an answer to that. And I would add just last that there's also some discussion around what's the actual level of herd immunity or vaccine uptake that we need to achieve in order to effectively achieve herd immunity and slow the spread of COVID-19 globally. So with that, I will end my presentation, and I think we'll open it up to discussion.
Thank you, Dr. Duncombe and Dr. Castell, for your informative presentations. So we do have some follow-up questions here. The first one, and either of you can respond or you can both respond. So what do we know about people living with HIV and risk of acquiring COVID-19?
So maybe I can go first. I think if you look at the data that I presented, it just, there are some studies that tell us that there is an increased risk and some studies that tell us that there's not an increased risk. And I don't know how to explain that. The geographies are different. Some of these are conducted in Europe, some in the US. We don't have any studies from sub-Saharan Africa, so that's kind of a big unknown. So right now, I think what CDC has said and what Amanda mentioned and what WHO has said is that there may be a signal here that there is an increased risk, and we need to make sure that people living with HIV protect themselves as best they can with social distancing and masks, just in case there is an increased risk. But the jury is still out. I think we just have to wait. Hopefully WHO's big database will tell us more information, but there may be other things that are more important in people being at higher risk of acquisition, like ethnicity, like obesity, like other conditions. Another, access to healthcare as well. I think this is another thing. I think people have disparate access to healthcare, which may impact their risk. Amanda.
Yeah, no, I would agree with you, Chris. I believe that, based on the data that, again, it's evolving. We started off with having very small kind of case studies around HIV and COVID-19. And we are luckily starting to see these larger databases, these larger meta-analyses that can give us a better sense of the impact of COVID-19 or SARS-CoV-2 on people living with HIV. But I do think that the jury is still out as well.
Thank you. Next question. Is the rate of adverse events higher with the COVID-19 vaccine compared to other vaccines?
So the data that we have thus far are showing that it is not any higher than what we would expect in the general population for adverse events such as anaphylaxis, for example. Of course, when the vaccine started being rolled out and we saw that there were several cases of anaphylaxis among people getting vaccinated, that was, of course, worrisome initially. But again, if we looked and as we delved more into who those individuals were and their history of having severe allergic reactions, I think it became clearer that it was not higher than what we would expect in the general population.
And are we monitoring adverse events for COVID-19 vaccination, and what do these look like?
Yeah, so with any type of vaccination, there are systems in place for us to monitor individuals. So the CDC, for example, uses the VAERS, the Vaccine Adverse Events Reporting System. They have the Vaccine Safety Data Link data. And now with the COVID vaccine, there's the vSafe, which is once you get vaccinated, you can sign up to get a daily text message asking about side effects and symptoms related to vaccination. So there are mechanisms in place to be able to monitor these types of potential adverse events. And if there is an early signal, then we'll be able to act on that immediately.
And do either adverse events or symptoms vary with the type of COVID vaccine given?
Shall I take that one, Chris? So, so the Pfizer and the Moderna vaccines, they're rather relatively similar. You know, people are experiencing some soreness at the injection site, some body aches, sometimes reporting low-grade fevers. But you know, that's the safety profile that we're seeing, or not the safety profile, but the side effect profile that we're seeing from these vaccines.
Okay, this question is for both of the panelists. Are you guys prepared to be vaccinated, and do you have a preference with the type of vaccine you would like to get?
I'm certainly prepared to be vaccinated. I'm just waiting very eagerly for that to happen. Preference I don't have. I think it depends on what's made available. We probably don't have a choice. Maybe we do. I can talk a little bit more later about just the rollout of vaccines in the state where I live and the sort of confusion that we've been faced with. Yeah, certainly there's no hesitation in my mind at all.
And Janelle, I'm fortunate enough to have already received my first dose of the Moderna vaccine because I'm a clinical provider in Washington, D.C. And so I have encourage everyone to get vaccinated. I strongly believe in vaccines. When the opportunity comes, I think it's really important for people to take advantage of it. You know, we've never seen anything like this in our lifetimes, a pandemic of this nature. And we know that there are particular communities and individuals who are going to be more affected. And so we really need to be able to get those individuals vaccinated.
Thank you. Next question. What is the response of people living with HIV to the COVID-19 vaccine, and what would you recommend? Should people living with HIV get vaccinated or not?
Yes, I think they should. As Amanda can also respond to this, but we just don't have the data because there was a delay in enrolling people in the clinical trials. We now have people with HIV enrolled in the trials, but we just don't have any data. I don't believe we should wait because this is life and death. It's a very serious matter, and people living with HIV, unless they have a particular feeling that they don't want to be vaccinated, they should be vaccinated, even though we don't have the data, because I worry that we look at the data, people living with HIV, if they do get infected, we've got 2 or 3 large databases now telling us that there's an increased risk of people dying. So this is very serious. And if you look at the risk and the benefit, even though we don't have the specific data for people living with HIV, I do believe that people living with HIV should talk to their providers and they should be vaccinated.
Next question. So let's shift a little and talk about vaccine distribution. How do you think your local area is doing with the distribution and provision of vaccines? Are they reaching the communities that are needed? Are they reaching the most vulnerable communities?
I alluded to this a little bit before. I live in Washington State, and it's really been quite chaotic. We've got large numbers of vaccines on the shelf that are not being administered. I spoke with my local pharmacy on Friday about when we might be able to have access through the pharmacy outlet. And they've had no communication at all from our state government. They have no planning. We've been waiting for these vaccines for a year, but still the pharmacy where, community distribution of these vaccines through pharmacies is really the way to go, not through hospitals. And I think anyway, this is how we're going to get large numbers of people vaccinated. But in my state, we seem to be still very unprepared. And as of Friday, it was people over 75, along with healthcare workers who could get vaccinated. And that was thought to be a bottleneck to getting vaccines out the door. And I think the politicians and the program people are now starting to feel the pinch a little bit, that people are saying, what are you guys doing? The vaccines are not getting out there. So just today, they lowered the age, and people over the age of 65 in my state can go. So it's a running target. But so far, I have to say, we're not doing very well in terms of reaching those communities who need it, whether it's people of color or whether it's the elderly. It's just not happening. But hopefully that'll change.
Yeah, I would agree, that the fact that each state has been left to decide how to prioritize the vaccines that they receive, um, and how to distribute them, I think has caused, as Chris said, a chaos. Um, so, I live in Maryland, but I work in the District of Columbia, and the vaccine rollout is very different between those two jurisdictions. The prioritization is slightly different. Um, DC was able to establish a wait list for individuals who were over 65 years of age. And Maryland, from what I gather, has not been able to do that yet. So this does create some sense of chaos. And then you look at other states like Florida, where older individuals have been able to get vaccinated. However, they've, sat in lines for hours waiting to get vaccinated. So this kind of piecemeal and not really nationally coordinated effort, I think, has presented some issues. And I agree that it's going to take, more than the local health departments and the clinics to really massively roll out a vaccination campaign in this type of setting, and that we really are going to need some federal assistance to do this.
And referring back to your slide set, there's a lot of COVID-19 vaccines distributed in the US, but not as many people receiving their first dose. Are we immune to COVID-19 with just one dose?
So that's the issue, is that we don't know. The studies, they would have to go back and do that research if possible. But that's not the way that the clinical trials were designed. They were designed to get the 2 doses and to look at the efficacy after that. So that is an unknown question. If there is a decision to, broadly roll out the first dose of vaccine to everyone, then we absolutely need to ensure that that second dose is available.
I think the other issue is that, if a person gets vaccinated right now, it kind of seems to be that the second vial of vaccine has to be labelled with that person's name and put aside and dedicated so that that person gets the second dose. That doesn't make a lot of sense when you're facing an emergency of, like we have with 3,000 people dying every day, that you're going to hold back 50% of your vaccines to make sure that everybody gets the second dose. It's a risk if we decide to give everybody their first dose and hope that manufacturing continues, and it's a balance of how we do this. But I know the new administration is seriously thinking about not holding back that second dose for everybody, because we just can't afford to do that, and just making sure that we keep the supply chain going so that all the vaccines we have are given to people, because these things have short half-life as well. The last thing we want to do is have people throwing them away, and that's a real threat. It's a real possibility that we're going to reach a situation where these vaccines are thrown away because they reach their expiry date.
Okay, next question. Does COVID-19 morbidity and mortality vary by geographic region? Do we have any databases that monitor this information?
Yeah, I didn't show. I did a presentation back in September at our conference where I showed the geographic distribution. There is certainly, for reasons I don't understand, there are countries and geographies like Europe which have good access to healthcare, but still the outcomes are not as good as other places. And again, as I mentioned, we just don't have any data from sub-Saharan Africa, so we just don't know. But yes, there seems to be a significant geographic variation in all the variables that we talked about today. Either acquisition, the risk of getting it, the risk of complications, and the risk of death seem to vary by region and by country. That's partly because of small sample size, I guess, and maybe WHO's large global database is going to help answer these questions. But it's not just geography. It's not just comorbidities. I think most of the studies tell us that comorbidities are really a significant driver. Just how geography plays a factor, and if people living with HIV are more at risk, I think the jury is still out.
Thank you so much. And This one is specifically for you, Dr. Castel. But Chris, you can also chime in. What is the impact of COVID-19 in an area with higher prevalence of HIV or a geographically dense metropolitan area compared to a rural area?
Yeah, so we've seen that cities have been initially were very highly impacted by COVID-19. Particularly areas for concern for me were such as Washington, D.C., where we also have, um, a relatively high prevalence of HIV in our community. In terms of COVID, generally, we've seen that, the entire swath of the United States, whether rural or urban or suburban, has been affected um, by COVID-19 at this point. But we certainly see that geographic distribution. One of the things that we're doing is a study looking at the impact of COVID-19 among people living with HIV. So there are an estimated slightly more than 12,000 people living with HIV in DC. And we do follow about 11,000 people through a longitudinal cohort study. And so we are starting to look at the incidence of COVID amongst that population, but also to look at the impacts in terms of the socioeconomic impacts, around housing, food, as well as access to supportive services and HIV services. So more to come on that.
And is service delivery being impacted by COVID-19, and how so?
So it was initially, and again, we're just starting to delve through our data, but there have been other studies that have shown that individuals who needed access to HIV prevention services, for example, or needed to attend their regular HIV visits, but were told that they were high risk and to stay at home, that those individuals, were more at risk. And so services were somewhat disrupted. We had several clinics just initially close until they could figure out how to provide services virtually. Telehealth is going to be, I think, has been a huge component of our ability to continue to deliver clinical services during the pandemic. And it will be interesting to see how telehealth continues to kind of remain a core part now, I think, of care delivery and the care continuum post the pandemic.
So that's the end of my questions, but I wanted to ask, what's the take-home message, and what should we be looking forward to knowing?
I think in terms of how people living with HIV are affected by this virus, the take-home message is that we have evolving and conflicting data, and we need to get more data to understand if there's a problem. There is certainly a signal there that you can see there may be an issue that we need to pay attention to in terms of whether people living with HIV are more at risk, whether they fare worse. But we just need more data.
And I would say that with respect to the vaccines, that they were developed rather quickly, but they still went through a rigorous scientific process. And so I think that we should be able to reassure people that we did follow the science and the vaccines are effective, and that now that they are available, that we should try to avail ourselves of getting vaccinated. Hopefully that wherever you live will be able to implement a vaccine rollout program and distribution program that is timely so that we can prevent all of these unnecessary deaths. We've seen rates surpassed every day over the last couple of months in terms of infections, hospitalizations, and deaths, with over 4,000 deaths in the US, I think is one of the, peaked. And so it's really important now that we make sure that we get people who are at risk access to preventive measures such as vaccinations.
And I think that concludes our questions. I don't think we have any additional questions from our audience. But thank you so much, Dr. Castell, Dr. Duncombe, for your presentations, your information, and We look forward to hearing more and to knowing more as we progress scientifically, and look forward to hearing from you guys again.